Good afternoon to one and all. Thank you to the organizers for giving me this opportunity, and thanks to my mentor, Dr. Kritthivasan sir, for giving me this opportunity as well. So I have a long list of abstracts, and I think it's better we get on with it. So I've grouped the abstracts into chemoimmunotherapy, those with ADCs and those with epidemiology the last. So the first one is a long-term follow-up with anthracyclines in the early breast cancer trials. So these were a series of 3 adjuvant trials. They compared docetaxel cyclophosphamide through anthracycline-based regimens. The US Oncology Research, the NSAPP B46 and B49, almost 2,000 odd patients each, the joint efficacy analysis for IDFS. The prior non-inferiority hazard ratio they had set was 1.18. At a median follow-up 3 years, the HR for TC6 versus TAX-AC was 1.2. So the non-inferiority of TC could not be proven then. So this is a final analysis of ABC trials for IDFS at 6.9 years of median follow-up. They remain consistent with the original results. The TAX-AC regimen, that is anthracycline-based regimen, reduced any recurrences as first events, but with an increased risk of leukemias and non-breast cancer deaths. With respect to recurrence-free interval, there was significant favor of TAX-AC. The subgroup that seemed to favor most was the hormone receptor negative cohort. And with respect to OS, there was no significant difference. When we compare the deaths non-breast cancer related, there were 34 versus 62 in TC versus TAX-AC. There were 1 versus 7 leukemias. The reduction of recurrence was offset by leukemias and deaths unrelated to breast cancer, which I think is the most important point here. Moving on to a modified Keynote 522 regimen for TNBC. This is from the MSKCC. So, as alluded to the previous speakers today, we know that the AC regimen which is used, doxorubicin epirubicin based regimen is used in Keynote 522 is not dose dense. And we have listened to Dr. Sharada Ma'am's talk today, and we know that the dose dense regimens have a survival benefit. So, the investigators here modified the Keynote regimen. They used a dose dense AC with 3-weekly carboplatin with weekly paclitaxel. So this was a retrospective study with a majority of patients in clinical stage 2. Almost 50% of the patients received AC first, 50% received taxol carbo first. And here the overall PCR was 56%. There was no difference per se. Whichever group did first, there was no difference in PCR rate, but the AC regimen delayed the taxol carbo in 58% due to clinically significant neutropenia as opposed to the opposite. For example, when taxol carbo was given first, there were only 29 or 30% delay in AC. Investigators actually, in the discussion, they had actually alluded this to GCSF. When giving AC, we usually give GCSF or PEG GCSF. This requires bone marrow milieu to be exposed to GCSF. So, probably an apparent decrease in the stem cell reserve. This is quite hypotension. So again, the 3-weekly carboplatin had higher PCR rates and lesser treatment delays. This also, they had probably extrapolated better synergy with higher AC carboplatin. Coming to the neoadjuvant camrelizumab, this is from China. So camrelizumab is a PD-1 inhibitor approved in China for multiple indications: Hodgkin's lymphoma, nasopharyngeal carcinoma, squamous cell carcinoma, the esophagus, etc. This is almost a Keynote 522 regimen with camrelizumab instead of pembro. So they have used an AppAcli backbone with EC, followed by with camrelizumab 200 mg every 2 weekly. After surgery till 1 year, they received camrelizumab. The primary endpoint was PCR here. So baseline characters, almost 440 patients were randomized, and 85% were PD-1 positive. 1/3 of the patients were high node negative, that's node positive, N2 and N3, and stage 3 were almost 35%. So the primary endpoint was met very well, though the PCR per se was lesser than the Keynote 522. The difference, that is the delta, was almost maintained, 12.2. Maybe one could say that the higher percentage of node N3 patients were more represented here. And among the high-risk patients, stage 3 as well as node positive, there was a good difference in it is a good significant PCR was obtained with camrelizumab. And age more than 40 years, good performance status, nodal status, node positivity, and clinical stage 2 were having a good response. But again, like Keynote 522, it was not dependent on PD-1 expression. The survival trends are yet to mature, and as anticipated, the grade 3 events were almost same, but almost 10% of the patients had to discontinue camrelizumab in the treatment arm. So coming to ivonescimab, there is a safety and efficacy of ivonescimab in first-line TNBC. So this is a new molecule, that's a tetravalent bispecific antibody. It binds to both PD-1 as well as VEGF. So what is important here is a cooperative binding. That is, when suppose a molecule binds to VEGF dimer, This increases the sensitivity of the molecule to bind to more PD-1 and vice versa. The molecule also contains Fc silencing mutations. This significantly reduces the antibody-dependent cell cytotoxicity. Hence, it increases the biological half-life of the molecule. So, keeping this in mind, this is a single-arm trial to see the efficacy and safety in metastatic locally advanced unresectable metastatic TNBC with a nab-paclitaxel or paclitaxel backbone. So, almost 30 patients have been enrolled. As we can see, more than almost 50% had more than or equal to 4 mets, and only one single patient with brain mets were there. Almost 2/3 were recurrent metastatic. Prior 60% had a taxane use, and 80% had PDL1 CPS less than 10. So, an objective response rate was almost 72% with a PFS of 9.3 months, median PFS. Here we can see the CPS negative, that's PDL negative group, out of 16 patients, 13 had a PR. While which is actually good for a new molecule, and I think more data is awaited in this regard. The most common adverse events were hematological, mainly asymptomatic ALT and AST elevations, and hematological with on-paper neutropenia and anemia. There was no TRAs per se leading to discontinuation or death. Coming to toripalimab with nab-paclitaxel, again metastatic or recurrent TNBC. So here the data based on chemoimmunotherapy in the first line metastatic have yielded mixed outcomes. So for example, IM patient 130 was a positive trial in PDL1 as well as ITT. IM patient 131 was a negative trial. Keno 355 had a better outcome in the PDL1 positives, more than 10%, while more than 1% is not significant. So this was trying to fill the void in that regard. They have randomized double-blinded placebo-controlled phase 3 and metastatic or recurrent TNBC. They excluded visual crisis. They excluded untreated active brain metastasis. The PDL1 was done by JS311 assay, which almost showed some 85% concordance with 2-C3 for pembrolizumab. The primary endpoint being PFS. So baseline characters, we know the CPS almost 1/3, 40% of the patients were PDL1 negative. Previous taxane, 80% had not been exposed. Almost 2/3 were recurrent metastatic. Most common states of mets were lung and bone. So we have a significant PFS of 2.8 months, which is significant. 8.4 was the numerical median PFS, while this was in the PDL1 positive population. While in the ITT, that's the intention to treat, the 1.5 month delta was not statistically significant. Among the subgroups, more than 65 years of age and those with liver mets, they fared poorly. And this OS actually data is not mature, but the descriptive OS they have given as 13 months is quite dubious because in the subsequent anti-cancer, subsequent therapy, which they have given as a supplement, the systemic treatment received, that's the PDL, the percentage of patients on the placebo group who have received immunotherapy is only 6%. So definitely time will tell when the data matures. And with regards to safety, almost 8.5% had to discontinue toripalimab, and any grade SIE was almost 10% more in the treatment group. So coming to the Alexandra IM patient 03, which is again a negative trial. So on the background, IM patient 31, this actually had a atezolizumab with a nab-paclitaxel and AC regimen backbone. This had a significant increase in PCR rates regardless of PDL1 status. So the investigators wanted to explore the role in an adjuvant setting, the primary endpoint being IDFS. At the median follow-up of 25 months, they had set a HR boundary of 1. The observed HR was 1.12, and in view of futility, the trial recruitment stopped. So at final analysis, the HR for IDFS was again 1.11, which is again futile. The addition of atezolizumab to adjuvant anthracycline and taxane-based chemo did not improve IDFS in the ITT population. Coming to two very good interesting trials, response-guided neoadjuvant sacituzumab govitecan, the NEO-STAR trial. So as we know, SG, I'll just shorten it as SG so it's easier. So it's we know there's a drop to humanized IgG and ADC. If the payload of SN38 payload, which is a topoisomerase 1 inhibitor, it has a cleavable linker, and with a bystander effect as well. So this is an investigator-initiated platform clinical trial. So something which is to be remembered regarding these type of trials are there are multiple molecules evaluated at various stages, so that the patient gets the benefit of all molecules. For this trial, in this arm, it is included TNBC, ER less than 10%. Any tumor more than 1% or not positive were permitted. We are analyzing the results of the first cohort only, that's the A1, where single agent SG, 10 mg per kg day 1 and day 8 were given for 4 cycles every 3 weekly. They serially assess the patients with MRI, and if CR or near CR, they proceed with surgery. The option of neoadjuvant chemotherapy or adjuvant chemotherapy were given according to the investigator discretion. The primary endpoint being PCR. So what we can see, around 50 patients enrolled. Overall PCR with SG alone was only 30%. Overall response rate was 64%, and with a median follow-up almost 18 months, the 2-year EFS was around 95%. But those with the PCR had an EFS of 100%. As we can see with the patient characteristics, most were stage 2 disease. Node positive was only 18%. BRCA negative were 80%. So here, among the 15 patients who had PCR, 14 had received additional neoadjuvant chemotherapy apart from SG. And the 21 patients overall, out of the 50, required additional neoadjuvant chemotherapy post SG. Out of 21, 7 had PCR. So this just says that overall, even though the molecule is efficacious, that alone might not be the key in getting the patient to a PCR. So TROP2 overall was not predictive of response. Higher K67, higher TLs predicted response. This is a personalized approach with response-guided escalation and de-escalation. It is well tolerated molecule with grade 3, almost 5 patients having grade 3 neutropenia and diarrhea. And again, another platform clinical trial, datopotamab deruxtecan in I-SPY 2.2. So just comparing the molecules side by side, this is dato-DXd. This is a tetrapeptide-based cleavable linker with an exatecan derivative, which is almost 10 times more potent than the SN38. Again, it has a bystander mechanism, and being a more stable molecule, it has a lesser adverse effect profile than SG. So this was a very complex trial design. So I'm trying to explain as best as I can. There are 3 blocks of patients. This is 3 sequential blocks. Block A was experimental treatment. A lot of molecules were tried. Single agent, dato-DXd, dato with the durvalumab, etc. And the block B was actually optimized according to subtype. For example, if the patient did not have a PCR in block A, they escalated to block B, where they were given Taxol carbo-based chemotherapy. And the block C was actually sort of a rescue block, where patients who are not performing well in block A or B got rescue chemotherapy with AC. So this was more of a data-directed therapy, where the pre-RCB, something called the pre-residual cancer burden, was used. This is an algorithm to assess the probability that the patient has achieved a PCR. If the pre-RCB is high, the patient foregoes the treatment in subsequent blocks and goes straight to surgery. If there is a PCR the pre-RCB is below a certain threshold, they proceed early to next block so that to avoid potential toxicities. They used mRNA functional volumes and something called the RPS, response predictive subtypes, which is derived from MAMAprint, imprint, and blueprint gene signatures. So here we can see HER2 negative, immune positive, were almost 44% of the entire cohort, which is all 106 patients. So efficacy, dato-DXd was very, very efficacious in this immune positive cohort. Again, overall, across all blocks, the estimated PCR with dato-DXd in the immune positive cohort was 77%. But what we have to notice in the immune negative and the DRD negative cohort, the estimated PCR was 44%. This is actually a very difficult to treat cohort, as we had alluded to earlier in the discussion. This is something called the cold tumors, which don't respond to anything. So here we have dato-DXd as a very good molecule to use in the future. And discontinuation due to dato-DXd was 2% and durvalumab was 5%. There was one grade 4 stomatitis which required discontinuation of dato-DXd in the trial arm. So here, immune positive subtype are the best PCR rates. This immune negative DRD negative subtype, even though there were very less patients, it is very hard to treat good, and this molecule has a lot of potential in that regard. And coming to our data, retrospective data from India, Dr. Jyoti Bajpai and team, this outcomes of non-metastatic TNBC from TMH. So almost 1,300 odd patients were analyzed with some points which were very striking was young breast cancer, less than 40 years, almost 60%. And BRCA positive, even though 14% had a family history, almost a lot of patients were actually counseled, only 9% underwent testing, out of which 3.1% turned BRCA positive. Local advanced were the common presentation of almost 50% local advanced breast cancer. Almost 1/3 were lymph node positive, and out of all the patients, 40% had a PCR. So treatment characteristics, almost 250 patients were metastatic at diagnosis. Platinum agents were used in 14%. Among deaths, 320 were due to disease and 2 due to chemotoxicity, and especially in such a high volume center with just 2 patients due to chemotoxicity deaths, this is very commendable. 55% underwent PCS. So this the authors are actually told that it's more center specific, and as and when the time improves and the patient surgeons get the confidence and the radiation team also helps in this regard, the percentage of BCS is going to increase further. So adjuvant RT had got almost 80% had got adjuvant RT. So survival outcomes, median DFS was 92.2 months, median OS was not reached. Out of the 20% who had disease recurrence, the distant disease was in 55%. Both local and distant was in 23%. The common failures were in lung, liver, bone and brain. So out of multivariable analysis, age, more the age, stage, advanced stage, LVA and PNE were the where variables affected DFS and OS. So the largest study and patients were younger, higher grade in stage 3, high rates of DCS. The intensification of therapy with platinum and capecitabine could be difficult because of the poor socioeconomic status and the logistics constraints. And of course, therapy with ICS and PAR-based, even though we talk so much as in academic center, it's very out of difficult for most patients in view of logistics. In view of significantly decreased OS for stage 3, the onus should be on the early detection. So the last one, the innovative staging system for de novo MBC.
You'll have to make it early.
Last one, ma'am. Yeah, ma'am. The MBC, the all stage 4 have been lumped into one category. So this by Dr. Jennifer Plishta, the staging system was to risk stratify patients with MBC, which is currently an unmet need. So they had actually tried to divide the stages into stage 4 into 4 groups with different survivals, like more than 70% to less than 25%. This is actually published in JCO and a lot of times validated. The most of the analysis was based on clinical T stage, grade, ER, PR, HER2, organ mets and the number of organs involved. So after the initial validation, which is published in the JCO in 2023, now they have validated in other subgroups as well. For this validation, they have taken patients from Netherlands, France, Colombia, Mexico and Spain. This validation cohort included almost 11,200 patients and odd, which is between 2002 and 2021. And despite these variations in sample size and data collection, the staging system was consistent in its performance. This is an online calculator which can be used to risk stratify patients on stage 4 breast cancer. Thank you.